Okay, this lecture is about pelvic organ prolapse, types and stages. Before we start talking about prolapse, let's remember some anatomy and see what keep the genital organs, the uterus, cervix, vagina, what keeps it in place in the pelvis. Just to remember the anatomy, this is the uterus, usually anteverted. It ends with the cervix. This is the vagina, and this is the opening of the vagina or the vestibule. In front of the uterus is the bladder. This is the urethra, and this is the opening of the urethra. Behind the uterus is the bowel. Here's the sigmoid, the rectum, and this is the anal verge. Now, the area between the opening of the anus and the vagina consists of some muscles called perineal body. Now, as you see, the genital organs are sitting on the pelvis on a firm ground consisting of the pelvic floor muscles and the perineal body. This is the ground where the vagina is sitting on. Now, if we look at the vagina from this side, what keeps the vagina in place is a connective tissue surrounding the vagina, connecting the vagina to the pelvic side wall. And if we go up to the cervix and the uterus, what keeps the uterus in place is two dense fibers of connective tissue at this levels of the internal os of the cervix, going to the side wall of the pelvis, what we call the cardinal ligaments. There are also two ligaments from behind, starting from the cervix and going back all the way to the sacrum. It's called uterosacral ligaments. So two uterosacral ligaments and two cardinal ligaments from each side. This is what holds the uterus in place. There also we have the round ligaments, and between the round ligaments and the pelvic side wall there is a broad ligaments. But the supportive role of the cardinal and the uterosacral is more. This consists of the apical support of the uterus. In the next picture, we're seeing some form of prolapse. Now, just to talk briefly about the type of prolapse, this area which support the organs and keep them in place, if we have any weakness, they will push inside the vagina. For example, if we look at the anterior wall of the vagina here, between the bladder and the vagina, we said there's connective tissue. In this area, it forms a fascia which support the anterior wall of the vagina. If we have weakness in this area, then the bladder will bulge inside the vagina. If we look at the posterior wall here, the area between the rectum and the vagina called the rectovaginal septum. This supports the posterior wall of the vagina. If we have weakness here, then the rectum will push inside the vagina and we'll have a bulge in the vagina. If we have any problem with the support of the uterus will go down inside the vagina. Now, if we want to stage this and use a simple rule, then any bulge which remain inside the vagina is a stage 1 or grade 1. If the bulge reach the hymen ring or the opening of the vagina, then it is stage 2. If the bulge go outside the vagina, then this is stage 3. We'll talk more in details about staging later in this lecture. Now, according to what we've said, if we look at this picture, we can see that, for example, the uterus has fallen down. This is the cervix, is reaching the introitus or the hymen ring. So we have stage 2 or second degree uterine prolapse. If we look at the anterior wall of the vagina, you can see that the bladder is pushing and the bulge is going outside the vagina all the way out. Is about 2 centimeters outside the vagina. This is a third degree cystocele or third degree anterior wall prolapse. If we look at the posterior wall and see the rectum hole here is pushing also, and we have the rectum is about 1 to 2 centimeters outside the hymen ring or outside the vagina, and this is third degree rectocele or posterior wall prolapse. Okay, so let's go on to the next slide. You can see here everything is outside. This is fourth degree prolapse or procedentia. We'll explain what this means later. So, pelvic organ prolapse etiology. The most important factor and the strongest risk factor is the parity. The more children you have, the more likely you'll have prolapse. Increase parity and maximum birth weight. Big babies are risk factors. Instrumental deliveries are risk factors. Obstructed labor, risk factor. Age and menopause, conflicting evidence, but we notice most of the prolapse in old ladies. Constipation and straining, anything increase the intra-abdominal pressure on a chronic basis will cause prolapse. Heavy lifting, obesity, chronic pulmonary disease, also risk factor for prolapse. Hysterectomy. When we do hysterectomy, we cut the apical support, cardinal ligament, uterosacral ligament, and that is a risk for vault prolapse. Colposuspension is a risk factor for enterocele. Sacrospinous fixation is a risk factor for anterior wall prolapse. Hysterectomy, if we compare the vaginal route to the abdominal route, the vaginal route, we have damage to pudendal nerve. So the vaginal route is more risk for prolapse according to Benson, but there is another researcher who found that the vaginal and the abdominal route had the same risk for vault prolapse. Collagen abnormalities, connective tissue disorder associated with prolapse. Women with genital prolapse have increased joint hypermobility. Women with genital prolapse, more proportion type 111, weaker but flexible. Anyway, and just to conclude, collagen abnormalities are if you have problem with connective tissue. The connective tissue is the main component of the ligament which support the uterus and the vagina, so you might have problem. So 50% of women develop prolapse, but only 10 to 20% of them seek medical advice, because if it's embarrassing to talk about prolapse symptoms or even to go to a doctor to examine you for prolapse. That's why only 10 to 20% of the patients go to doctor. From these 10 to 11% they have lifetime risk of single operation. But they have 30% chance free operation. Okay, so mechanism of normal supports of uterus and vagina. Interaction between pelvic muscle, as we said, the pelvic floor, pelvic muscle, levator and nape group, and connective tissue which support the vagina. Levels of the vaginal support: level 1 or apical support, cardinal ligaments and uterosacral. Level 2, arcus tendinous white line. This is a line we'll show you on the pelvis where the connective tissue travel from that line to the vagina, supporting the middle part of genital organs, the vagina. Level 3 is the perineal membrane and body. Okay, this is the white line, and this is the connective tissue from there supporting the vagina. This is the normal anatomy. Here, if we look at this picture, we'll see the bladder is bulging and going outside the vagina. This is 3rd degree cystocele. The uterus is up in its place and the rectum is in its place, so we only have cystocele. Anterior vaginal wall prolapse or cystocele. It's pathological descent of the anterior vaginal wall over down bladder. There's 2 types of cystocele: distension and displacement. Distension, if we have weakness of the fascia covering the or between the bladder and the vagina, the whole fascia is weak, so you have symmetrical bulge. If we have only one area, then we have displacement. Only one area is bulging. So this one is distension, and this one here is displacement because only one part is defective. This is also a cystocele reaching the introitus, so it's just by looking without examining a 2nd degree cystocele. If you look at this picture, the bladder is fine, the rectum is fine, only the uterus is going down, but still within the vagina, so this is 1st degree uterine prolapse. Epical prolapse or uterine involved, damage to the uterosacral and cardinal ligaments, as we said, loss of the integrity of the anterior and posterior vaginal wall, post-hysterectomy or vault. If you look at this picture, we're grasping the cervix and pulling it down, so it reached the opening of the vagina. So this is a 2nd degree uterine prolapse. As you can see, there are stitches here, so the patient is sleeping during operation in theater, and this is the best time to assess for prolapse, because the way you assess prolapse is you pick up the prolapsing part and pull it down to see how far low it can reach, so you can define the degree of prolapse. But you can't do this when the patient is awake because it's painful. So in the clinic, when we examine the patient, we ask them to cough, so we see indirectly something to push this organ or prolapse, so we can see how far down it reached, so we can classify it. But when you have the patient on the table sleeping, then you can grasp it with a grasper and pull it down, and this will give you more accurate picture about the prolapse. So it's quite normal that you assist the patient in the clinic, and you say, for example, she has 2nd degree uterine prolapse or cystocele or whatever, and when you examine her in theater before the operation, you find it's 3rd degree because you can pull down further. This is a 4th degree prolapse. 4th degree is when everything is prolapsing. The total length of the vagina minus 2. For example, if the vagina is is 9 to 10 centimeter in length. If 7 centimeter or above is outside the vagina, then this is 4th degree prolapse. This is another type of prolapse. Here we have 3rd degree rectocele. Can you see the posterior wall is going out? This is not the cervix. This is a lady who have hysterectomy, and this is the vaginal vault. So basically what we have here is the 3rd degree rectocele or posterior wall prolapse and 2nd degree vault prolapse. In this picture, you see the bladder in its place, the uterus in its place, only the rectum is prolapsing, going outside the vagina. So this is 3rd degree rectocele or posterior wall prolapse, 3rd degree posterior wall prolapse. Now, so what are the types of prolapse we have? If we have the anterior wall of the vagina prolapsing, this is called cystocele or anterior wall prolapse. If we have the posterior wall prolapsing, this is called rectocele or posterior wall prolapse. If the uterus is going down, this is called uterine prolapse. If the area, the top area of the posterior fornix is prolapsing, behind which there is a pouch of Douglas, and usually the small bowel go in the pouch of Douglas when you stand up. If you have defect in this area, the small bowel might push through the top part of the posterior vaginal wall or the posterior fornix. This is called enterocele. So we can have enterocele, anterior wall or cystocele, posterior wall or rectocele, and uterine prolapse. Okay, so here we have, for example, this is uterus, cervix, vagina, and here bladder. Okay, this is the anterior wall intact. This is the posterior wall. We have the rectum is pushing here, still within the vagina. So this is 1st degree rectocele. We also have enterocele, the top of part of the posterior fornix. The bowel is pushing here. Then this is enterocele, 1st degree enterocele. Okay. What are the symptoms of prolapse? Generally, all the women will feel bulge or heaviness, something bulging in the vagina, like a lump, dragging sensation, backache, vaginal dryness, or irritation, especially if the prolapse is 3rd degree and the tissue is outside. Need to push the prolapse back after straining to defecate. In severe cases of posterior wall prolapse, when she try to defecate, the stool will push the posterior wall of the rectum and it will push inside the vagina, and it will not go to the anal canal to pass the stool. So the lady have to put her finger inside the vagina to push the posterior wall to support it. So when she pushed or strained, the stool will go to the anal canal and she can pass stool. This is called digitation. Sexual activity embarrassment or painful. Urinary dysfunction, especially when you have anterior wall prolapse or cystocele, stress incontinence, bladder neck hypermobility, frequency urgency, occult stress incontinence, voiding dysfunction, recurrent UTIs and ureters. Symptom related to rectocele: incomplete bowel emptying, obstructed defecation, constipation, inability to empty the rectum without reducing prolapse, digitation, fecal incontinence of rectal prolapse. Grading system, as we said, 1st degree, 2nd degree, 3rd degree, we explained that. The same for rectocele and enterocele. Now we'll talk about something called POPQ, which is basically a system to classify or quantify the prolapse by numbers, so it gives more accurate description of the prolapse. If we look at the picture here, we have the vagina, we have cervix, uterus, we have here the bladder, we have the rectum here, or here, this is the rectum. Okay, so we have to look at some landmarks. The POPQ system is a table, 3x3 tables, which has a number. Each row of them mainly designed to describe one part or portion of the genital organ. So when you want to examine this part, you look at that row and it will tell you exactly what's happening with that row, the degree of prolapse. How we do that? Let's first look at the picture and define the thing we can see in the POPQ. This area is the opening of the vagina. Okay, it's called the genital hiatus. Okay, this area between the posterior fourchette and the anal verge is the area of the perineal body. Perineal body. Now, the genital hiatus should be around 3 centimeters. Okay, less than that, you have vaginal stenosis, and more than that, 4 or 5. 3 to 5 is acceptable. 5 is you have vaginal widening. Perineal body should be around 3 centimeters. Less than that, we have deficient perineum. This area from here to here is the total length of the vagina. The total vaginal length should be 9 to 10 centimeters. If it's less than this, then this is a short vagina. Now, this area is the cervix. It's the C point. So when we see C point, this is the area of the cervix. The cervix should be at least 7 centimeters above the hymenal ring, or the opening of the vagina. So this hymenal ring is the landmark for description of the prolapse. Anything above it described as minus. Minus mean above the hymenal ring. Plus mean below the hymenal ring. Okay, so this cervix should be minus 7 centimeters or above. That's normal. If it's less than 7 centimeters above the hymenal ring, then you start having prolapse. If it goes up to -1, this is first degree. If it goes to 0, this is 0. The hymenal ring level is 0. If it's go to 0, then second degree. If it's plus, then third degree. If it's plus all the vaginal length, -2 centimeters, which means if it's more than 7 centimeters outside, then this is fourth degree prolapse. It's for the uterus. Now, how we describe the prolapse for the enterocele, for example. The enterocele is, this is D point. The D point is usually 1 to 2 centimeters above C point. Is 1 to 2 centimeters above the cervix. So this is -8, -9. If it goes below 7, then you have prolapse. So if it goes up to here, this is first degree prolapse. Up to the opening or the hymenal ring, up to -1, this is first degree. If it goes into 0, second degree. Outside is third degree, outside the vagina. If it's +1 and below. Now, how we describe the anterior and posterior wall prolapse. Now, here we don't have landmarks, anatomical landmarks, so we will put imaginary point landmarks. So we have this area or this point called A, anterior, and we have B, anterior. A, anterior, is 3 centimeter above the hymen ring. So A, anterior, is -3. B, anterior, is 6 centimeter above the hymen ring. So it's -6. The same thing on the posterior wall. We have A posterior and B posterior. Now, if we have, let's say, the anterior wall bulge here, the bladder is bulging inside, and the lower point is going down, 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 up to -3. Up to -3, we still consider it normal. Even if B reach -3, we consider it normal because the vagina has folded and rugae, and it's very flexible tissue, so it might reach up to here. But if it's below -3, then this is prolapse. The same thing for A point. If it's below -3, then this is prolapse. So if it's -2 or -1, regardless if it's B or A, this is first degree cystocele. If it reaches 0, the hymen ring, then this is second degree. If it's +1 or below, this is third degree. If it's all the vagina outside, more than 7 centimeter outside, this is fourth degree. The same thing for the posterior wall. So these are the points we look at, and this how we describe prolapse by PubQ. We'll see example. Now, we explain the stages. Now, this is the PubQ. So, 3 by 3 tables. The first row, AA and BA, describe the cystocele, the anterior wall of the vagina. If you want to look for cystocele, look at these two numbers. C, which is lowest, and this is the degree of prolapse you have, regardless if it's A or B. It doesn't matter if it's A or B. For example, if this is -1 and this is 0, then the lowest point is 0. So this is second degree prolapse. Okay. C point describe the cervix, so it gives you idea about uterine prolapse. It should be, we said, -7 or above. If it's less than that, then you have prolapse. The middle row is anatomical measurements of landmarks. So this is always plus. There's no minus in this because this is genital hiatus, the opening of the vagina. This is the perineal body. This is transvaginal length. The last row or the third row, the first two, AP and BP, A posterior, B posterior. This is for the posterior vaginal wall or the rectocele. You see the lowest point, and this reflects the degree of prolapse. And D for the enterocele. Okay, for example, if we look at this PubQ, when we look at PubQ, we should be systematic. First, we look at the anterior wall, +8, +3 and +8. Which is the lowest? +8. What's +8? +8 is fourth degree cystocele because it's more than 7 centimeter outside the vagina, almost the whole length of the vagina. C is the cervix. The uterus is +8. Also, it's fourth degree uterine prolapse. Genital hiatus, 4.5, slightly high genital hiatus, slight wide vagina. Perineal body, 1.5 centimeter, should be 3 centimeter. So this is deficient perineum. Vagina is 8 centimeter, should be 9 1 centimeter less, that's acceptable. If it's below that, then it's short vagina. The posterior wall or the rectocele, +3, +8, +8 is bigger, then this is also 4th degree rectocele. If you look at this one again, anterior wall +3, +6, +6 is more, then this is 3rd degree cystocele. -2, cervix is 2 centimeter above the hymen, should be -7, so this is 1st degree uterine prolapse. Slightly wide vagina, perineal body deficient, short vagina, 6 centimeter. -3, that's normal. -2 is just 1 centimeter below, is 1st degree rectocele. Here, -3, that's normal anterior wall, there's no cystocele. -6 centimeter, the uterus is, the cervix is just 1 centimeter below normal. This is 1st degree uterine prolapse. Wide vagina, deficient perineum, and just normal vagina. +2, +5 rectocele, so this is 3rd degree rectocele. Now, management option for prolapse. Counseling first, explaining the result. Most people, they don't want anything, they just want to know that this is not cancer, this is just laxity of some tissue. So no treatment, pelvic floor exercises, conservative such as physiotherapy or pessaries, surgical treatments. 100 types of pessaries. This is a ring pessary, put it around the cervix here to push the anterior and posterior wall. The aim of the prolapse surgery, alleviate the symptoms, restore the normal anatomy, restore normal visceral function, avoid new bladder or bowel symptoms, preserve sexual function, and avoid surgical complication. Classification of prolapse surgery, we can have vaginal surgery, abdominal surgery, or laparoscopic surgery. Many types of procedures. Conclusion, pelvic organ prolapse is common. It results from injury to soft tissue and nerves, and the cause of this injury mainly deliveries and childbirth. Childbirth most significant association. Treatment require understanding of anatomical relationships. Treated with a combination of physiotherapy, pessary, and often complex surgery. And that's all about prolapse.